Hello and welcome back to Advanced Human Gross Anatomy. Today, dissection number 20. Can you hardly believe it? Today we'll be talking about the brain, the cranial cavity, and the muscular and carotid triangles. But we'll start by reviewing the brain and where it used to be as it's set within the cranial cavity before we took it out. And then we'll finish today by looking at the anterior portion of the neck. So if you remember the telencephalon here, the brain, the cortexes of the brain, the telencephalon being right above the diencephalon, which is the thalamus, and hypothalamus, which is right above the brainstem, right in front of the cerebellum. Here is just the hemispheres taken out. We call it the telencephalon. So the hemisphere, here, let's look at the lobes again. Remember, you saw the temporal lobe is kind of like a thumb of the mitten here, the frontal lobe being in front, parietal on the top, and then occipital in the back. And then the insula is this area here of the temporal lobe, kind of an inside, kind of found within. You can see how Netter has pulled the forceps back here so we can see in between the frontal and parietals and this edge of the temporal is this inset cortex called the insula. Let's look and review some of the functioning here. Hearing. The primary association for hearing, primary auditory cortex here is right at the top of the temporal lobe here, and then the surrounding areas are going to be for hearing association, and then that will also kind of with connections into these language centers back here as well. So, but hearing is going to be right up in that front of the top portion of the temporal lobe. The occipital lobe you can see back here. This is the left hemisphere. Here you can see the right hemisphere here in that the calcarine fissure, or the calcarine sulcus. That longitudinal fissure would sit right on top of here between the hemispheres. Here's the occipital lobe for where hearing is. Primary auditory is going to be right in the middle and then going inside that calcarine fissure, or the sulcus there. The secondary areas for association are going to be surrounding it, coming this way. And then they're also going to give connections in a couple different ways to other cortexes to help give meaning to what we've just heard. Okay. For instance, I hear a baby crying and I know that that's my baby. I recognize that. So the association areas are going to be around that primary center. The parietal lobe, you can see the central sulcus is color coordinated for us here. Behind that is blue, in front of that is red. Here's the sensory and the motor on each side, each hemisphere. But in back of the central sulcus is the primary somatosensory cortex, this post-central gyrus here, and this is going to be sensory information coming from the body. Comes here first before it will travel to other areas for interpretation and if something needs to happen, if there's motor control, then we can move from there. But the sensory input is coming into this post-central gyrus. And then the frontal lobe here is going to be in front of the central sulcus, and the first gyrus in front of this, the precentral gyrus, is the primary motor cortex, and this is again going to be motor response to any of the sensory information that we've just received. You can see the big green area in front is this prefrontal cortex. This is executive reasoning, personality, decision-making, complex social behaviors, that kind of stuff happening up in the frontal cortex up there, the prefrontal cortex. The lateral sulcus is what separates the temporal lobe from the frontal and the parietal lobes right here, lateral sulcus. The longitudinal sulcus, I don't have a good shot of that, but that's what this is a section going through that the longitudinal sulcus, kind of a mid-sagittal sulcus between the two hemispheres. Here's a funny image. It's called the homunculus, which is a funny word for a funny image here. Now, don't get confused at this picture. This isn't looking at the right and left, if you're looking anterior to posterior, the right and the left hemispheres. We're looking at the motor cortex and the sensory cortex, but this is going to be the precentral gyrus on both sides, and this is going to be the postcentral gyrus on both sides, okay? But there's a mapping here. You can see these kind of outlined by red indicating motor and blue indicating sensory. These are where this cortex is where the nerve cell bodies are found for sensory information coming from the body and motor innervation of axons going to the body, right? So the nerve cell bodies are what are found here. And so this is a picture indicating how much surface area, how much geography is actually given to each of these places on the body. So you can see on the inside, down that longitudinal fissure, the genitalia, the toes, the feet, the knee, the leg, the hip, the trunk, the arms, the elbow, the forearm, the hand. Look at the surface area given to the cortex for the hand and the face. Wow, the face gets a ton. The larynx, the tongue, the teeth, the gums, the face gets a lot of real estate here on the brain, on that cortex, and the primary somatosensory cortex. Likewise on the motor, same kind of thing, but look at the hand and the face here. Lots of information coming from these areas and going to these areas. So obviously in our development, this is something that our body feels is important. Dexterity in your hand, facial expression. Look how much nerves these cell bodies are designated for these particular areas. That's kind of astonishing to me. Let's now spend some time looking at the circulation to the brain. Now, this is helpful in working with patients who have had strokes is a primary reason for this, but really any time where you're going to have an occlusion or compromise to a vasculature within the central nervous system, knowing which vessel is affected will help determine some of the likely areas that are going to be involved from that. What's important here to know is that the brain is basically supplied by 4 vessels. 4 hoses feed the brain with blood. You've got the internal carotids on each side and the vertebral arteries on each side. So those 4 vessels are what is responsible for bringing blood to the entire telencephalon and the cerebellum back here too. Okay, so the internal carotids, like I said, are here. These are coming. Let me go back to this picture here. This might be helpful. Remember that the internal carotid artery enters the carotid canal way back here by the jugular canal, and it goes through the carotid canal here. The carotid frame, and going into the jugular, the carotid canal through that petrous portion of the temporal bone. And then it exits right here and goes over that foramen lucerum and then sneaks itself up kind of the side of the body of the sphenoid before it lets off a branch called the ophthalmic artery. Remember that? And that's going to give rise to a couple of important arteries, the supratrochlear, supraorbital, lateral nasal, coming in onto the face, coming up onto the head. But then right here it continues up, and that's where we pick it up here. That's where we pick it up right there. So I know we're looking at the underside of the brain, but imagine this put back in that skull case like it was. Okay. So they come up on each side. Then the vertebral arteries are coming up here. Now these originate off of they're the first branch off of the subclavian arteries. They travel up through the transverse foramen of the cervical vertebrae. Remember those? And then they enter the cranium right alongside the brainstem here as it enters the foramen magnum on each side. So we're picking those up right there as the spinal cord becomes the medulla. Okay, now starting back here at the vertebral arteries, let's talk about some circulation here. So the first branch off is going to be right here and right here on each side, the posterior inferior cerebellar arteries. Nitter has abbreviated that PICA, P-I-C-A, posterior inferior cerebellar artery. Guess what it does? Guess what it supplies? That's right, the posterior inferior aspect of the cerebellum, right? Pretty easy so far. As we continue up the vertebral arteries, they each give a branch off that joins in the center of this anterior portion of the brainstem and then continues down the spinal cord. These are the anterior spinal arteries, and they join together here. So again, branching off from each edge of the vertebral arteries, coming down the ventral aspect of the spinal cord. As they come together, these 2 vertebral arteries join, And where it joins, that becomes now this basilar artery. The basilar artery is important here. It's right on the ventral surface of the pons. You can see the pons on the front side here. And remember that the brainstem here does a lot to help keep us alive. And so a stroke or an issue with the vasculature here is life-threatening. If you have a stroke in the basilar artery, that's going to be a significant problem and likely not going to survive that. There's a test we do in the clinic called the vertebrobasilar insufficiency, where we would kind of extend the neck as far as it goes and then turn it a little bit, or just kind of extending the neck completely can put some pressure on that junction. And if you get lightheaded or if you start having visual changes, then we know to stop that test. But if you have a compromise here, that's half your brain's blood supply is occluded, and that's not going to serve you well. Now, coming off of the basilar artery, on each side at the front of the pons here are these smaller branches called, I missed one. Sorry. Right after the basilar artery is formed by the joining of the two vertebral arteries, you have another branch here. Now, if you had a posterior inferior cerebellar artery, guess what you also have here is an anterior inferior cerebellar artery. A little tougher to say AICA, but PICA and the AICA come off, but the anterior inferior cerebellar goes to the anterior inferior portion of the cerebellum, but it comes off the basilar artery here. Continue that north, well, in our picture anyway, toward the pons. Now, right off the basilar artery are these little branches. You see all these branches? Those are just collectively called pontine arteries, supplying the pons. Continue up here. Now, right here, just before the basilar artery stops, you have another branch right here and right here. Two arteries were designated for giving the inferior aspect of the cerebellum. Now there's a superior cerebellar artery right here and right here going to the superior aspect of the cerebellum. Okay, and then immediately after the pons ends, right here, the pons basically bifurcates into these posterior cerebral arteries. Now we're not going to the cerebellum, now we're actually going to the cerebrum. Okay, the posterior cerebral arteries on each side are going to supply the posterior aspects of the cerebrum. So think of what that's going to give here. Here you can see on the bottom of that temporal lobe here, the parahippocampal gyrus next to the hippocampus. So that's going to give issues with memory, potentially. If there's a damage to these vessels, they could cause some necrosis in the areas of the cortex associated with memory. Facial recognition is also back here in that area of the cortex. Occipital lobe, think of vision, could be affected if you've got an issue with the posterior cerebral arteries. From there, the posterior cerebrals are going to go forward, branching off of the posterior cerebral arteries towards the, connecting them to the internal carotid arteries are these posterior communicating arteries. These are just bridges between the posterior cerebral and the internal carotid. So hopefully that is pretty easy to see there. Now, right off of the middle of the internal carotid are these middle cerebral arteries. Now, the middle cerebral arteries travel laterally off from each side. They travel kind of underneath. Here you can see the temporal lobe is still intact. Here you see they've cut that anterior portion of the temporal lobe off so we can see where it actually travels. It goes underneath that anterior portion of the temporal lobe and will supply the lateral portions of the cerebrum out here. Now, if you remember that homunculus, this includes the pre and the post-central gyrus. So this is motor and sensory information coming to and from the body, respectively. So a stroke in these middle cerebrals is a big deal. You're going to lose a lot of sensation and motor control both from and to the body. If we continue now, off the front of the internal carotids are these anterior cerebral arteries on each side, kind of hooking around, coming forward. And now these are going to be traveling anterior, supplying that middle aspect of the cerebrum, also into the frontal lobe. So think of things like personality, behavior, social reasoning, that kind of things could be affected with an issue in this vasculature. And then bridging those two anterior cerebrals, this little kind of bridge right in front is that anterior communicating artery. So if we take now, let's take the, one of the issues here is this, they call this the circle of Willis. I was going to show you this picture here. Well, I'll just start with this one. Let's just start with this. Now, they call this the circle of Willis. Is the kind of this is a the map of what we're looking at here. So it surrounds the hypothalamus and the pituitary gland, which is shown here. So probably should have just kept this picture up for a minute. So here's the hypothalamus and the pituitary, and this provides, this is important here because the hypothalamus is monitoring for blood sugar, protein content, fluid content in the tissues, thirst, hunger, temperature, blood pressure. I mean, all sorts of stuff is happening from that hypothalamus. So that becomes really important. If we go back to this picture, though, hopefully you can see the loop, the circle of Willis. From the basilar arteries as they split here, it provides the opportunity for some collateral circulation. If one artery isn't responding or functioning quite as well as it should, sometimes the tissue can still be perfused from blood from the other side getting at it, coming around a potential occlusion. And so this can create the possibility for you to be asymptomatic for a little bit longer if these issues do exist, which is kind of nice. So again, this picture is a little funny. Don't necessarily study completely from this shot, because what we've missed now is the posterior inferior cerebellar arteries, which are branching off of the vertebral arteries below where this picture is drawn. They're coming this way. And then right below where it's cut here, I would say right about there would be the branches of those anterior spinal arteries coming down this way to the anterior portion of the spine. Now we pick it up where the vertebral arteries join together into the basilar artery. The first branch off the basilar is that anterior inferior cerebellar here. Then you've got the pontine branches, and then you've got the superior cerebellar on each side. Then as the basilar artery splits, comes this way, bifurcates, that becomes the posterior cerebral. Hope I'm saying cerebellar and cerebral right. Superior cerebellar, posterior cerebral. Middle cerebral, anterior cerebral. So between the posterior cerebrals and the internal carotid is this posterior communicating. Off of the internal carotid, coming laterally, is the middle cerebral, and then coming forward is the anterior cerebrals. And then they join together at the anterior communicating. So posterior inferior cerebellar, anterior inferior cerebellar, superior cerebellar, posterior cerebral, middle cerebral, anterior cerebral, posterior communicating, anterior communicating. Whew, hopefully you got all that, but we'll just keep moving. Okay, now let's take a look at the skull from inside, looking at the cranial cavity. This is where the brain used to sit before we took it out in a previous dissection here. So the dura, actually what yours will probably look like is more like this. The dura will still be attached. Now you cut here, you cut this portion of the tentorium cerebelli out kind of on both sides of the transverse sinus. Remember that? And it kind of took this out so that we could get the cerebellum and brainstem to come out with the brain. Otherwise they would have just gotten ripped off there. But yours will look more like this with some of that dura still intact. But let's go over some of the things we're going to find in each of these cranial fossas here. So the anterior cranial fossa, got a couple things here. The orbital plates are right here. This is just below here is the orbit. The roof of the orbit is kind of what this creates. And in a future dissection, we'll chisel through this. We'll kind of cut through and break apart that orbital plate to expose the eyeball, the superior aspect of the eye. So we'll see the muscles and the vessels and the nerves that supply the eye in a future dissection. But the orbital plate is right here. Here you have the lesser wing of the sphenoid sitting right up on top, kind of on the back side of the anterior cranial fossa. And then the cribriform plate is right here on each side with the crista galli sitting up front of the ethmoid bone. And that's where that bulb of the olfactory nerve will sit and then travel backwards toward the cortex. Lesser wing of the sphenoid, like we said. The olfactory bulb is going, the nerves are going to come up through the cribriform plate and exit back. Also, the other cranial nerve that you'll see here is the stub of the optic nerve, which is going through that optic foramen. Also coming out here, we talked about that internal carotid sending a branch of vasculature through that optic foramen as well. The ophthalmic artery is going to come into there before it comes up to this picture, what we just saw earlier. Okay, let's see. Kind of right in the front lateral aspect of the sella turcica is where that optic foramen is. Okay, middle cranial fossa, this portion right down here. A bunch of stuff happening in this area as well. The superior orbital fissure, you can't really see it. It's right underneath the lesser wing of the sphenoid here, right at the kind of on the front edge of this. You could see this through the orbit if you looked at it straight through, but you'll see a big slit right here, a big opening going towards the orbit. And a lot of stuff is actually happening here. The ophthalmic division of cranial nerve number 5, V1, is going to exit through here. The oculomotor, cranial nerve number 3, trochlear, cranial nerve number 4, and abducens, cranial nerve number 6, will all exit right through that superior orbital fissure. Also, the ophthalmic vein will drain blood back towards the cavernous sinus from here too. So the ophthalmic artery left here going through the optic foramen, and the ophthalmic vein is going to return through the superior orbital fissure here. Okay, foramen rotundum following straight back from there. This is that round hole. We learned this as the mandibular division of cranial nerve number 5, V2, will exit the skull here. And then the foramen ovale, which is right here, this is going to be where hopefully I said that right, the mandibular version, the mandibular division. So the maxillary division, boy, I don't remember what I said, but I don't want to go back. So let's start over. Ophthalmic division of V1 is going to go through the superior orbital fissure. V2, the maxillary branch, is going to go through the foramen rotundum. And the mandibular branch, V3 of the trigeminal, the maxillary, is going to go through the foramen ovale as it exits. Now, just behind that, you see here this little hole. It's called the foramen spinosum. This is where the middle meningeal artery will enter the skull. This is off of the maxillary artery, off the side of the skull here, and it's going to send a branch right up there. I should be able to see this in the dura here, but you can see there's a groove right between the sphenoid and the temporal bone. And that's going to be where this middle meningeal artery will sit. And you might be able to see that today in the when you look at the dura. It should be that middle meningeal artery. Let's see. Hypophyseal fossa. Oh yeah, the hypophyseal fossa. Looking at my list of terms here. This is just where the pituitary gland sits within the sella turcica. Kind of that depression in the saddle. The fancy word for pituitary is the hypophysis. So the hypophyseal fossa, where the hypophysis sits, the pituitary gland sits right here. The cavernous sinus is going to sit right on the edge here of the body of the sphenoid. This is a large sinus. I think it's easier to see it here, obviously, because it's shown, but that's this large sinus right here. You can see the ophthalmic vein draining through the superior orbital fissure back into that cavernous sinus. But it's also draining portions of the cranium, the meninges, the orbit, all sorts of stuff is coming back into here. Surrounds that whole cavernous sinus will surround the pituitary gland as well on both sides. And you'll see in this picture here, you'll start to notice some of the stubs of the trigeminal. Here you can see the oculomotor, you can see trochlear, abducens. You'll see some of those nerves coming out into this area next to the cavernous sinus. So as you're looking at the cavernous sinus, check out some of those nerves as well. Now let's go back to the posterior cranial fossa. Obviously the big one here, the foramen magnum, the big hole in the back, that's where the spinal cord's coming up. The hypoglossal canal, which is just kind of on the anterior lateral portion of that foramen magnum, that's where the 12th cranial nerve, the hypoglossal nerve, will exit the skull. Here you've got the jugular foramen. There's a lot going on here. If you remember, let's go back to this picture here. This is where the sigmoid sinus is draining into the internal jugular vein. Also that the inferior petrosal sinus drains right into the the internal jugular vein as well. The glossopharyngeal nerve the glossopharyngeal number 9 and vagus. You can see those two right here on each side. Cranial nerves 9 and 10 will exit that way as well through the jugular foramen, and spinal accessory. Now, spinal accessory is funny. Oh yeah, here it is. Spinal accessory actually comes up through the foramen magnum because it comes from the spinal nerves, and it comes up and then exits out that carotid foramen, that jugular foramen rather, as well, with all that other stuff. So there's a lot going on as it travels down into those areas. Okay, let's see what else is in this posterior cranial fossa. Go back to this one. The internal acoustic meatus right here. You should be able to see that in the temporal bone. This is where cranial nerve number 7, the facial nerve, and 8, the vestibulocochlear nerve, are both exiting the cranium right through there. And, like I've just kind of gone through all the cranial nerves, you should be able to see all of these cranial nerves still, kind of these stubs, still intact in the skull, even after the brain has been removed. So here's what that future dissection will look like. As well as you look at I'm just looking at this picture, that orbital plate has been removed, and we'll be able to see this, I think, next time. Okay, so let's go through the cranial nerves here and just see where they are within the skull. Number 1, olfactory, coming right off that cribriform plate on each side. I'll just do one side here so you can see it, the right side. Cribriform plate, right above that's the olfactory bulb, going into the olfactory nerve, coming back to the cortex. Optic nerve, coming out that optic foramen. Number 2. Number 3, oculomotor. Right here, you should be able to kind of see that going out into that superior orbital fissure. Number 4, trochlear, and V1 of 5, trigeminal, going out the superior orbital fissure here. V2 of cranial nerve number 5, the trigeminal, goes out foramen rotundum, and V3, the mandibular, is going to go out the foramen ovale. Right, so ophthalmic, maxillary, mandibular divisions of 5. Now 6, we kind of skipped here. 6 is just the next one in line, but 6 abducens will also go out superior orbital fissure toward the eye as well. 7 and 8, these are exiting that internal acoustic meatus, facial and vestibulocochlear right there. 9, 10, and 11 are going out the jugular foramen. 9, the glossopharyngeal. 10, the vagus, and 11, spinal accessory, coming out that way. And then 12, going out the hypoglossal canal right to the side of the foramen magnum. So again, you should be able to kind of notice all 12 cranial nerves on each side. Hopefully you should be able to see this on your dissection that you've been working on. Okay, let's now shift gears and talk about the neck. This is a big shift of gears, but I think it's a good one. Now, we'll talk about the muscular triangle first here. The muscular triangle is really just this space right here. It's made up of, the boundaries are 3 muscles. One is called the omohyoid, which is here traveling underneath the sternocleidomastoid and going down this way to the scapula. It's kind of a strange one. We'll talk about that in a minute. Another boundary is the sternocleidomastoid. Here's the sternal attachment, the clavicular attachment going up to the mastoid process of the skull there. And then the hyoid bone would be that third leg of the triangle. So there's your muscular triangle on each side. Now, we're looking here at the strap muscles. So let's go to this picture first here. We've cut the sternocleidomastoid, so you can see here and here coming up to where it used to be. Here is a superficial dissection. So here's a couple of muscles, and then we'll dissect these to get down to the deeper ones here. So we'll be able to look. The first one we'll talk about is the omohyoid. Now this is maybe one of the most unusual muscles in the body, if you ask me. It actually inserts. The insertion is at the hyoid bone. Its origin is way over here on the scapula, on the superior border of the scapula. And superior notch. And there's a sling that it goes through, kind of this fascial sling right by the clavicle as it loops up and around this way. So it goes right down over this way next to that internal jugular to attach up onto the hyoid bone. Really interesting muscle. It helps to depress the hyoid, so it's going to pull it down in the larynx. It kind of helps to depress that. Right next to it, medially on each side, you can obviously, well, I'm not going to switch pictures here, but here's the omohyoid cut. right there. Here's its other, the other branch of it. And then here's the other one called the sternohyoid. Now the sternohyoid goes right from the sternum and again inserts onto the hyoid. From here to here. Very cleverly named sternohyoid, right? Now if we take, here's the sternohyoid resected. So here you can see it and here you can see its attachments. Now deep to those are a couple other muscles here. The sternothyroid, you can see coming from the sternum up to the thyroid cartilage right there. So that's the sternothyroid, and then from the thyroid cartilage, continuing that direction up to the hyoid is the thyrohyoid. So those are the strap muscles: omohyoid, sternohyoid, sternothyroid, and thyrohyoid. So they just continue up from there. Now all of these are supplied by, they get their nerve innervation from the ansa cervicalis. Ansa in Latin means loop. And so these are nerves coming from the cervical spine, C1, 2, and 3. They kind of travel, here, let me show you a confusing picture here. They kind of come right along with I just blanked on cranial nerve number 12, hypoglossal. They kind of come right along with hypoglossal, but then they loop around, then they kind of switch gears here, and then they innervate the strap muscle. See, 1, 2, 3 coming on that ansa cervicalis. So if I ask you what nerves supply the strap muscles of the anterior neck, I've already given you the ansa. The ansa cervicalis is that one. Okay, now in today's dissection, I want you to think about, if, hopefully you never need to do this, but if you ever needed to do an emergency tracheostomy, where would that be? So if you find the thyroid cartilage, this big prominent, vernacularly we call that the Adam's apple. The thyroid cartilage is much more prominent anteriorly. The posterior prominence is going to be the cricoid cartilage, which is in the back, which is this next ring down, which is small in the front and wide in the back. Thyroid cartilage is wide in the front, small in the back. But if you find this little lip right in between those two cartilages, you can make a small incision and place a hole about the size of a pen right into the thyroid cartilage, right here, right below that, or right into the windpipe. This is the narrowest part, just above where the vocal, this is above this is where the vocal cords are located. But if a victim is having trouble breathing because there's an occlusion up in the glottis or the larynx, you can go straight down below that, and hopefully that will give them the opportunity to breathe and let air in and out of the lungs. But again, hopefully you never need to do that. But you can feel where that is on the cadaver today if you'd like. You could feel it on yourself as well, but I maybe wouldn't perform that on yourself today. That's just it's a lot of paperwork for me if you start giving yourselves tracheostomies in class. Okay, let's look now at the carotid triangle. Now, what's interesting about the carotid triangle is there's a lot going on in this area in between. So let's go back to that muscular triangle. Here's your carotid triangle now, inside of that muscular triangle. If you can find your pulse very easily, the carotid pulse, if you find the angle of the mandible and just drop straight down in front of the sternocleidomastoid right here, in front of that. And remember how to find your sternocleidomastoid? If you side bend toward the side that you're feeling and then rotate your head away, this will pop right out. So if you go right off the angle of the mandible, come in front of SCM, and you should be able to fall right onto your pulse there. It should be nice and strong in that carotid triangle. Other things found here. You've got the external carotid right here. And you've got the internal jugular vein. External carotid artery, internal jugular vein. Let me go back to this picture. Let me go to this one. Sorry. Here you can see sneaking through here is the spinal accessory nerve coming underneath the sternocleidomastoid muscle, the spinal accessory cranial nerve number 11, coming out of that jugular frame and coming underneath sternocleidomastoid. You can see SCM has been cut here, and they've kind of retracted it up. Here you can see it coming down and innervating, sneaking up to the underside of SCM, and then continuing on to the upper trapezius. That's the spinal accessory nerve right there. That's going to be there. The facial vein will kind of be right into that carotid triangle as well, or the carotid triangle. This is coming right alongside the carotid or the facial artery, which you can see how the carotid vein. Here's probably a better shot of it without the without the SCM in the way, but you can see how the facial vein just drains right into that external jugular vein. Now, this is an external jugular vein. Is actually, so you got the internal jugular inside the carotid triangle, and then here it's coming on the outside. So here's that facial vein going right towards. I'm sorry, I screwed that up, didn't I? I pointed at this one. The facial vein is actually going to drain into the external carotid artery, which is superficial to the sternocleidomastoid. Internal jugular is going to be deep to sternocleidomastoid. So here you can see the deep one. Superficial, we've cut off already. So here's the facial vein draining into the external jugular vein. Now, the external jugular vein, because it's superficial, you can sometimes see this. If you see this clinically, if somebody has a pronounced external jugular vein, that could be clinically troubling. If that stands out or is real prominent, it could suggest heart failure. It could be that the right side of the heart is failing to return blood back to the heart, so that should get checked out. Often, though, sometimes too, just for fun, you can tell if somebody's yelling or singing really loudly, if they're really using their voice, this external jugular will kind of pop out of their neck a little bit. You can kind of see that. This is a good test to kind of tell if somebody's lip syncing. If you're at a concert or you're watching something on TV and you're thinking, no way are they singing that and moving all like that. You could tell if that external jugular is popping. I think they're actually singing. If it's not, maybe not. I'd be a little suspicious of fakery there. That's just me though. Okay, hypoglossal nerve. We've seen that already coming down this way. Let's go back to this one here. The hypoglossal, coming out of that hypoglossal canal, sneaking around this muscle called the digastric muscle, which we'll learn later. This is going to go right to the tongue. So right next to, and through that hypoglossal canal to the side of the foramen magnum, hooking around. Here's that ansa cervicalis coming down to the strap muscles, looping around. Oops, sorry, clicked on it. Looping around there towards the tongue. Okay, now let's shift gears. Vagus nerve sits right in this groove too, but there's a better shot of it right here. Here you've got that the external carotid and the internal jugular. Here's that vagus nerve sneaking right down this way. So it's going to come right next to the throat. It's going to send off some branches that we'll learn in just a second, but that's going to come down there as well. If you check your pulse, interestingly, if you check your pulse by the carotid triangle, you may mechanically put pressure or stimulate that vagus nerve. And remember what vagus nerve does. It's 90% of your body's parasympathetic output. So that might actually slow your heart rate. If you want to get a very accurate pulse, I would not check it at the carotid triangle because of the vagus nerve's innervation there. But again, vagus nerve exiting that internal jugular, along with the internal jugular vein through that jugular foramen way up in the skull that we saw coming down this way. Let's see about this now. So vagus nerve coming down, it's going to split. There's going to be a branch of it that kind of comes right down here called the superior laryngeal nerve. This is again right off the vagus nerve, the superior laryngeal nerve going to the superior portion of the larynx, and then that's going to branch and give two branches. Here you can see the two branches, 1 and 2. It's going to branch into the internal laryngeal nerve, which is going to go and basically provide sensation to the glottis and the upper part of the larynx, and then the external laryngeal nerve is going to supply really only this muscle here, this cricothyroid muscle. You can see between the cricoid and the thyroid cartilages. And this is required to tighten up so that the vocal cords can be under the right amount of tension for speech. So that's going to be there. So again, vagus nerve is going to branch, and there's the superior laryngeal, which is going to branch into the internal laryngeal and the external laryngeal. Now, if you remember back in a previous dissection, we also talked about the inferior laryngeal, or back then we also called it the recurrent laryngeal because it kind of looped around and then came back up. Remember that one? And this one helps to innervate the rest of these laryngeal muscles to allow for normal speech. If you damage this inferior or the recurrent laryngeal nerve, you start talking like the Godfather, and it's cool in movies, but it's kind of annoying to talk like that, and it's kind of annoying to listen to. Maybe kind of cool for a while, but after a while, not so much. Okay, moving on to the vasculature. Last little part we'll talk about here. The circulation within that muscular and carotid triangles here will eventually be able to see the rest of these branches of the external carotid in a later dissection when we remove part of the mandible. But today we're not going to do that. So what I want you to see here is the carotid sinus. Let's just take a look at this. This carotid sinus is where the carotid artery is going to split into the external and internal carotid arteries. Okay, now this is under a lot of pressure. There's actually a lot of pressure receptors here. So if you press on this too hard, your body has a natural defense mechanism to shut you down. Oftentimes, you hear sometimes of kids doing this fainting game where they apply pressure to this area, or like a sleeper hold in wrestling if you're going to push on this area too aggressively, or if you had a tight sternocleidomastoid that was really putting pressure on that carotid sinus. What this can do is change the rate and the contraction of your heart, and it will slow enough and decrease your blood pressure enough that you might faint or just kind of lose consciousness for a little bit. Now, right here is also where it splits, though. Like I said, the internal and external carotid arteries are going to come down here. The internal is obviously going to go up in through that carotid canal as it enters the cranium, and then the external is going to come up here and really send up the neck to supply just about the entire surface of the head with blood supply, except for, remember, the internal carotid as it comes out of that carotid canal, across foramen lucerum, coming up the sphenoid, the body of the sphenoid, and then before it goes into the brain, it branches off into that ophthalmic artery. Remember that? Then that's going to split into the supratrochlear, supraorbital, this lateral dorsal nasal artery is going to come down. So though there are some portions supplied by the internal carotid, but much of it is supplied by the external carotid as it comes off. Now, this is under a tremendous amount of pressure, this external carotid artery. So if it is damaged, it will bleed a lot. If you have a cut on some of these vessels on your head, it can be kind of scary. There's a lot of blood, but just don't panic. Keep focused. Stop the blood by applying pressure at the right spots, and well, that's what you're doing now is you're learning, because you know your anatomy, you know where to press and how to stop certain areas from bleeding out. So what I'd like just to finish with here are the branches of this external carotid as it's coming up the side of the face here. We'll start at the very bottom here. This is called the superior thyroid artery right here, the superior thyroid, going right to the thyroid gland right there. Then there's going to be a branch off of that to the superior laryngeal right here. The superior laryngeal artery is going to be giving off blood supply to the superior part of the thyroid as well, in the thyroid cartilage up here. And then coming up from there, now you've got the ascending pharyngeal artery right here. The ascending pharyngeal is going to come off the back. Oh, I'm sorry, that's not it. My apologies. Superior thyroid, superior laryngeal. The ascending pharyngeal is off the backside. That's this one here coming up this way. Comes off the backside of the external carotid. There, I was looking at the lingual artery here. This lingual artery, again, right off of the external carotid, is going to give blood supply to the tongue, and there is a lot of blood supply to the tongue. If you cut the tongue off, and there's horrible stories of, governments doing this for spies that give secrets and stuff like that, you can actually die. You can bleed out of the blood loss coming from that lingual artery. So that's the amount of pressure that these arteries are under. And then the facial artery, you can see right here, coming up and over. The facial artery is going to be a branch right off the external carotid. And we lose it right here. It's going to come underneath the mandible. So it disappears a little bit underneath the angle of the mandible before it sneaks back around here and reemerges. Now remember, here is a spot where you can get a pulse sometimes. If you go right on the mandible itself, the body, sometimes you can get that facial artery pulse right there. The facial artery continues up on the side of the face, and then branches into the inferior and the superior labial arteries. Right here around the mouth, around the lips, and then it will continue up into this dorsal, the lateral nasal artery coming on the outside here, up into there. So what we won't see today is, because the mandible is still attached, we will take a chunk of this mandible off at a future dissection, just not today. But what we won't see today is really this maxillary artery coming up this way toward the maxilla. We won't see the posterior auricular branches coming off the back side of that. We won't see the superficial temporal branches coming up there, but we will once we get that mandible cut off. But that will be the rest of that facial artery that we'll see. I hope this was helpful. I hope that was informative and not terribly long. Hopefully that made sense. And I look forward to seeing you in lab, as always. Have a great day. Thank you for your time.